we thought we might try something a little different this year, and that is that we would engage you in a conversation between Miro and myself about some of the themes of misunderstanding that have come through to us over our years of working with patients, and also so that you'd have an opportunity to see how doctors actually share information with each other and talk about their experiences and learn from each other. And so we've had a chance to think about some topics that were that came to our mind, but we'd really like for you, if things come up for you, to come up to the microphone and ask us questions that you might have. And we're also lucky to have some of our other colleagues here who we can lean on for some of their wisdom as well. So just so you know, we decided that we wanted to think a little bit about language, and because if you talk about myths, by definition, you sort of are assuming that people have misinformation or misbeliefs, or that they are holding on to untruths. And I don't think that that's not at all our intention, because I think people come to their experiences in life, whether it's an experience of education or marriage or parenthood or your life at large. We all come with our histories, and we come with our family backgrounds, and we come from areas. We come from communities and geographic areas that form our beliefs and that guide us through our lives. So it's not a matter of people not being properly educated or not smart enough or anything like that. It's really more about the concepts that you come to certain experiences in your life. So the word myths, by definition, means kind of a mistruth, but I think that it's important to realize that people come to those understandings for really good reasons. So there's that, and then there's like traditions, which are experiences that families have over and over and over again that form family memories. And Huntington's being a family disease, many of those family memories are attached to Huntington's disease. And then there's folklore, which, thanks to the internet, is gone completely viral in the last 10 or 15 years, where families from all over the world have shared their stories. And because the internet is not well policed, there's an input circuit into the information that's on the internet that can be broadly true and broadly untrue. Are there any others that any of the other languages that we talked about when we?
Well, I think we talked about generally that regardless of languages, the background and the psychology is very similar across the different populations in different countries or different people. But every individual is unique, and every interaction with physician, patient, and family is unique as such. And everybody brings to discussion their own background, their own context. And there is no simple algorithm that you Google up and say, that's how it works, right? And that's why human-to-human interaction is very important. But then we are not computers. We are not robots. We are not 100% right all the time, right? So it has to be a certain amount of acceptance for what you Google up and what you face in the office, right, when you see a doctor. Because you can Google up 100 million things from internet, and physician may Google up 100 million other things from internet, and there may be mismatch for that reason, right? And it's important to understand that. It's important to understand that sometimes we can take a wrong turn on a highway not because we wanted to do, because we are just not computers or robots, right? So this has to be on the back of my mind when we're approaching this kind of interaction in the office with physician and patient. Particularly in disorders such as Huntington's disease, it's very complex, right? This is not disorder reactions Google up and then immediately you have straightforward answer what you need to do, right? And that's why you cannot also rely just on the books or internet. You have to rely on certain experience that you have a chance to encounter in certain specialized clinics that work and deal with Huntington's disease for a long period of time. Definitely you want to hear from more people. That's why we have multi-specialty, multidisciplinary clinics, because you don't want to hear from just one person, right? You want to hear from many different people, from different aspects, from their levels of views, expertise, and from your own experience, what is best suited for you in terms of treatment and how you're going to go through this process and incorporate it into your life.
So with that idea in mind, that is that there are a number of people who have some expertise or some perspective that's of value, I think it'd be really interesting to understand who's here today, so that we all get a better idea as we go through our day and we listen to what people have to say, that we understand ourselves kind of as a group. So how many people here are healthcare providers? So maybe 20%? Does that look like that's about 20% or so?
20, 30.
Something like that. How many people here are family members? The broad majority. So you don't have to answer this if you don't want to, but how many people here have Huntington's disease? So we're totally outnumbered.
Well,
We are.
it's the story of our lives.
That's right. We are totally outnumbered. But I have to say that, you know, having come to these meetings year in and year out, that the number of people with actually who had Huntington's disease has increased over time as we've held these meetings, which I'm like really proud of, that people feel like they can come someplace where they're, you know, where they're acknowledged and appreciated and that we're, you know, really happy to have you. And I would actually like to acknowledge the very first donor to HT Reach 10 years ago. Would you raise your hand? You can do it. There you are. He's the man who started it all off. He wrote a check before we could take it. He did. Thinking about that, how many people here are from North Carolina? How many people here are from outside North Carolina? Well, you guys are in the minority, but you're totally welcome.
Can I ask how many people are from South Carolina? Very good.
Yeah. That's pretty good. They made a long trip today, didn't they? Yeah. So how many people here would say that they feel like their family has managed Huntington's disease effectively? How many people here feel like their family of origin really struggled? About half and half. My experience is that the people that come to meetings like this tend to be people who are not necessarily satisfied with what they've seen from Huntington's disease in the past and would like to see Huntington's disease be different in their own lives. I don't know if are you like, do it? It doesn't work. Maybe I'll do this. Is that because I'm making too much noise? Is that better? Can everybody hear? Oh, good. Okay. So that's been my experience, is that people that take the time out of their life to come to meet other families with Huntington's disease are looking for ways that they can find other people who have handled Huntington's disease differently than their family of origin did, or that they really want to share what they've learned with other people, and that's a big way that they cope with what's happening in their life, is that they want to share their experience with other people so that other folks don't have to go through what they have. How many people would feel that that's true for themselves? Yep, so there's folks with that kind of approach to this as well. Okay. So one of the first things that when we talked about the idea that a lot of people, one of the myths that people bring to their experience of Huntington's disease is that their experience of Huntington's disease is going to be very similar to their parents'. That they have watched their parent go through an illness, and they said, well, they did that pretty well, and I want to do that, but they didn't do this so good, so I'm going to try something different. But in general, the fact that they watched how their parent suffered with Huntington's disease gave them a way to wrap their head around what's going to potentially happen to them. And there's some truth in that the gene expansion for Huntington's disease is sort of heritable, like you're more likely to inherit your parents' gene repeat, and then maybe that has something to do with age of onset, but I don't think that's either entirely true. So do you want to talk about that?
Yeah, I mean, even from the perspective of the science, we know that CAG repeat length is responsible just for 50% of the variance of the onset of the disease. So we have lots of modifiers of the onset. So your feeling that there's nothing you can do about onset of your illness is preconception, because other 50% of things are that we don't know what causes onset of at certain age. So there have been quite a bit of research. There has been quite a bit of research about modifiers, and some of those observational studies looked into it. So we now know that certain types of behaviors can accelerate the onset, and such as substance abuse. For example, common question that we have in our clinic is, Doc, how about a little bit of cannabis? Would that be good for me, right? And that is that common folklore culture that we have all over the internet, almost a religion, right? And I apologize if I may offend somebody with a question about cannabis, but that's a very common question that we have. And I never really knew the exact answer until just recently. We have I think February of last year, we had a publication for an Enroll-HD that really showed that substance abuse, illicit substance abuse or use, regular use, can accelerate onset of motor symptoms of Huntington's disease by about 4.5 years, particularly in women about almost 5 years. And 50% of those people that were followed used only cannabis, right? So we know the role of cannabis can be detrimental for motor onset of Huntington's disease. And we know from some other animal models and some prior non-published studies that it will cause euphoria, make you feel good, but it will affect your motor symptoms and onset of disease. So yes, there's lots of things that are interplayed with folklore, with preconceptions, with internet, with social media, and culture. But science is still a place to go and look into, and it is a long way to come to the final conclusion, what can help, what cannot help. So that's why interaction with physician is important. But being from this community of medical field, right? We know that even some of my colleagues don't know much about Huntington's disease. Even people in the same office with their neurologists, they come and ask me, so what do I do now, right? So it is really important to seek specific centers that have expertise on it and experience. Because you cannot just go and Google up something, because if you Google up numbness, right, 200 million hits initially is going to be multiple sclerosis. And then when you come to my office, you'll be convinced you have multiple sclerosis. And I will diagnose in 99% of cases, 99.9% of cases, they have carpal tunnel syndrome. So it's very similar with Huntington's disease. You enter something, you might have disproportionate representation on a computer interface about certain aspects of Huntington's disease, not the real life ones. So some things come with the experience. So you learn and see all kind of permutations of outcomes or interactions. And then when people ask you, you can tell them what is your experience and what would be your advice and how to go about certain things.
I think similarly, cannabis is like it's an illegal drug, but there's a legal drug that has an influence as well on onset of Huntington's, and that's alcohol. I think we know that from not just Huntington's literature, but other neurodegenerative disorders. So just to get super specific about it, a woman should have probably no more than 3 glasses of wine or 3 ounces of hard liquor a week. And for men, it's no more than 1 a day. And so that's for the general public who has no risk. So you can interpret that information for yourself if you have early symptoms or you're gene positive and you don't have manifest symptoms yet. You just need to take that into consideration in terms of your exposure to illicit substances. So, but at the same time, I think that it's important to know that the Enroll data, just like this Australian data that looked at alcohol use, it's not like they watched people prospectively necessarily for in a statistical design that would allow you to use that as a predictor. So although science is extremely helpful in terms of making good decisions for yourself, we're really at an infancy. And actually designing questions and getting accurate answers is infinitely more difficult than I ever imagined that it would be. You have to design a trial to answer a specific question. And there's only so many questions that we can answer, and I think the majority of the energy right now is being put into those questions are really around designing therapeutics to prevent or reverse the damage of Huntington's.
I was just wondering, has there been any attempt to deal with some of the herbs, natural herbs, research for that beginning to be looked at?
Well, there are definitely trials that are looking into it. I mean, trials, studies that are looking into it. We have prospective studies that have been going on, some of them for decades now, trying to look into different preparations, how they affect. Because when you get into the observational study, you try to convey as many habits or medications or exposures or anything that you ever had into the database, so you can generate a large number that we have power to extract the conclusion about potential effect of certain herbal preparation. Yeah, I think there is specific data on that. One problem that we have with herbal preparation is that generally you don't know what the active substance is. So, and from bottle to bottle, you don't know what is the exact mixture of the components. As a physician, I have seen, not too many, but like 2 or 3 cases that people were using certain herbal preparations that end up with severe liver damage, right? So you really don't know what is in it altogether. You know there are certain alkaloids, but you don't know how many or what is the proportions on them. So in terms of that, it's really hard to define how is it helpful or not. We don't know any specific we don't know about potential harmfulness about it either, right? But we don't know about benefits.
Stem cells? You're asking if there are studies going on about stem cells? So there's some work being done in California with pluripotent stem cells being injected into the striatum. I think that that's an ongoing trial, and that we don't have the results of that yet. That's my understanding. Is that yours as well?
Yeah, my understanding is we don't know exactly the benefit of it. There are some information we learn along the way, but not in terms of that would be something recommended as a mainstay in therapy.
So I have a question.
Sure.
Let me bring it back. Oh, thank you.
So if I have a family history of Huntington's disease, or if I'm a person who's at risk, one of my parents has Huntington's disease, then is it true that pretty much I can look at that person and kind of gauge, like for instance, if they developed Huntington's disease in their 50s, then, you know, I can pretty much kind of gauge that it's going to be like that for me too, or I can look at how it's progressed for them, and I can say, okay, well, it's going to be similar for me also. I'm going to develop it at the same age, and it's going to progress the same way or at the same pace.
Well, I think there's two questions there. One is the question that we talked about earlier, and that is that you can have two people with the exact same cage repeat length from the very same family and have very different symptoms of Huntington's. But I think the as important a question really is not just entirely the science about it, but the world around us is changing so much. Many years ago, people with Huntington's disease were put in psychiatric facilities, and they were dosed up with really high doses of drugs to make their chorea go away, and they were horribly apathetic, and they lived out a certain kind of a life. I mean, that's like how people died in their 40s with Huntington's. And then, the next generation of people who had Huntington's were probably, the first people there was enough knowledge around to be able to say that the movement disorder you have looks like Huntington's disease, as opposed to it being Alzheimer's or Parkinson's. And so people got a little better at diagnosis, and so those folks experienced Huntington's disease in a slightly different way. And then the next generation of people, their children, was the generation where the gene was discovered, and there had been a body of there'd been a growing number of healthcare professionals who began to get interested in Huntington's disease and started to try different things, and they started to communicate. And the way that person experienced Huntington's disease was different than their parent. Now, we have kids getting tested in their late teens and early 20s and preparing their life for Huntington's disease in a way totally different than their baby boomer parents. And so their experience of it is going to be very different. Plus, we know a lot more about Huntington's disease now than we did 20 years ago. We know that people have symptoms 7 to 15 years, psychiatric symptoms for 7 to 15 years before they develop motor symptoms. We know that people lose their jobs, and they have family issues, and they have interpersonal problems years before they get motor symptoms. And so the way that these kids that are being tested years before they develop symptoms are going to have a very different experience, not to mention the fact like in the middle of this, there's been this explosion of understanding about genetic diseases in general, and now, you know, this opportunity for disease modification, which may vastly change what Huntington's disease looks like 10 years from now. I mean, it may be a disease of side effects and minor motor symptoms. I mean, I don't know how to tell somebody who is young and tests positive for Huntington's disease now. Like, I can tell them to prepare for what I know Huntington's to be today, but that doesn't mean I can tell them what Huntington's is going to be like when they become manifest. And I think it's a balancing act, you know, like, we don't want to really be overly optimistic about these trials, but I think we need to be realistically optimistic that Huntington's disease may be something different in the future. Is that, I mean, do you see it that way?
Yeah, I agree. The looking into, you know, extrapolating that symptoms are going to be exactly the same as in you know, parent or sibling is a little bit fatalistic approach. Like I could not do anything about it, and so that's how it's going to be. But this time around, I think this time, first time around, is the situation that we are having very promising pipeline of new treatments coming that completely might change this. And that's why we have more and more people becoming subjects in their own, rather than objects in this story, that they want to try actively seek to be involved into Huntington's disease community and the studies and research trials, because we are now on the verge that we are coming with some potentially very beneficial treatments. But will not happen without individuals with Huntington's disease at risk or family. So people realize now that it is more and more involvement that will change the outcome. And I think that is something that is going to continue, and we will encourage it to involve more people into the community and be part of all these major studies and trials that will help to find something. This time around, we can see something, some light at the end of the tunnel, right?
Yeah.
So this is the first time around, and we have the first generation that has that opportunity. So yeah, that question is a question that is one of the myths.
Yeah, yeah.
I got it.
I'd like to ask a question about I call it the missing decade of 35 to 45. I'm 52 now, and I got diagnosed 4 years ago with Huntington's. And there's 5 siblings in my family. My mom had it, and 2 have chorea movements, and they came on at about, you know, their 50s. But my oldest sister has none of the chorea movements. But we all have impulse control. We don't spend our money wisely, credit card issues, bankruptcies. For a decade, from 35 to 45, I wrecked my finances, I wrecked my marriage, I had agitation issues. Thank God I didn't drink or do drugs. But if I had been tested 10 years earlier, and you know, I think my ex-wife and I spent $10,000 in counseling, you know, where you come from an alcoholic family and you got this issue and that issue. And if we had hit that, well, I have Huntington's, and I put some safeguards in place of not dealing with the impulse control, maybe I gotten on Prozac earlier, that decade might have been a lot smoother. So without the chorea movements in that mid-period, what kind of testing can you do? Can you do a CAT scan? Like if I'd have had a brain image done at 30 and 35 and 40 and 45, brain-wise, would you be able to see anything? That's the question I have.
So I think that you bring up a really, really excellent point. And I think that the myth here is that chorea is the onset of Huntington's disease. And it's not. Huntington's disease is a psychiatric disease with motor manifestations. I can say that because I'm a psychiatrist. I'm sure Bert Scott, who's out in the audience, would, that's it. But it begins as a psychiatric disorder, and in many, many people. The cognitive symptoms start a long, long time before motor symptoms, like losing scent, like losing your smell is one of the very first things, losing the acuity of smell, and losing the ability to discriminate facial expressions is one of the very first things that's lost. Is 7 to 15 years before people get motor symptoms. And I understand completely why. It's because chorea is visible, and you can measure it. You don't have to biopsy people's brains, and it's a hard finding. Like there's a rating scale that's really, it's a hard finding. And the psychiatric manifestations or cognitive manifestations of Huntington's are much more difficult, and they're not. It's not like 10 years before, like if you know you have a cage repeat length of 42 and you know that you are X age, you can calculate sort of a disease burden scale and have some statistical ability to predict when someone's going to develop motor signs, but that doesn't say that the trouble that you're having with your wife today is because of Huntington's disease. And practically speaking, what you would like to be able to do is to say, what we're dealing with is we're dealing with a biological illness and not a character disorder. That's really what you would very much like, you and your wife would have liked to have known that, so that you can start to develop some compensatory strategies to make up for the executive issues and executive functioning that you're starting to lose. And we don't have that magic combination of neurologic or neurocognitive testing, but we're getting very close to that, plus these measures of disease burden and so forth. So long story short is that we need to get a lot better during that stage of disease, during prodromal Huntington's disease, before there's motor findings. And that's really on us. That's really on us to figure that out. And I think that the myth has always been that Huntington's disease is chorea, and that's the onset of it. But it's really a research definition. It's not a clinical one. And people have lots of problems before they develop.
There's a lot of damage emotionally.
Yes. Way beforehand. Yes. We know that. Which is why I think that this population of young people who are getting tested earlier and the PREDICT data and so forth is so powerful. But so from the medical side, the myth is that chorea is the onset of Huntington's disease. From the family side, and I think it's this impression that there is no help for people during that stage of disease, so why go get tested? And that testing is this big scary thing, and that you have all these risks that you incur by being tested, that when in fact there's this magic moment where knowing is to your benefit. And that's really different for every single person, but I think that my experience, and I'd be real interested to hear from the other healthcare professionals in the room, and that is that most of the time people end up going for a diagnosis when there's overwhelming information in terms of your performance in life that it's probably Huntington's disease.
Well, my symptoms are varied at times, but I just know that even looking now, how would a normal person react to this? Just by doing that self-evaluation mechanism has helped me continue working.
Yeah.
And I give the Lord the credit too, but that's one of the mechanisms I do.
right. Yep.
And that is because of medication?
Medication for the first 2 years, but I'm not medicated right now. It was causing me to sleep too much. I was on Prozac. The Prozac stabilized me and basically got back to exercise and eating right and some other things. But the last 2 years, I haven't had any medication at all. But I'm willing to go back on it if I need it.
Well, I think one of the most, one of the moments I've been the most moved by being part of the Huntington's community was the first time I heard you tell that story.
Yeah, basically, I had lost my dignity after so many mistakes. You know, I'm a former Navy SEAL. I graduated high school, Greenwood High School, and a combat veteran. A little bit of PTSD, not too much. Didn't drink anymore. Have lived a life, and all of a sudden I'm doing impulse control issues, hitting walls, just doing a lot of crazy stuff. and I just didn't know how to handle it. I didn't know what was going on. And I guess because I was so physically fit, we knew my mom had Huntington's, and I knew one of my sisters had it. But I would catch myself catching stuff off a table or somebody throwing something at me and me catching it. And I had just so linked Huntington's to the chorea that I didn't realize that my own impulse control issues and anger issues were clinical. And when I got, after 10 years, just it's hard for a woman to see their husband overspend and anger and anger and anger, and I had lost my dignity. Not her fault, just I'd lost my dignity. And when I found out I had a clinical disease, I felt like I got my dignity back. I'm dealing with a clinical monster. Nothing wrong with the psychological monster either. Those are real. But it just helped me come to terms with what I was dealing with.
Yeah.
So.
And that is a great point, actually, and the moving story that really exemplifies how important it is sometimes to know. There is a moment that it's important to know that you are not dealing with your issues, that you're actually dealing with the illness, right? And then objectively approach it, to be able to dissect when you're acting yourself, call yourself to deal with the illness. And I think it's also important for the clinicians to understand that chorea is not the first symptom. We know that psychiatric and cognitive symptoms can occur decades before motor symptoms even occur. And one of the detrimental outcomes of that is that people would underperform at their job because of attention span issues, irritability. They lose their job, and then they lose their benefits. And with losing their benefits, they lose their medical care. They lose, they get in that vicious circle of down spiraling. So it is really, and ourselves with psychiatric background that are sensitized to psychiatric issues, in our clinics, we will address that early, and we have our social worker really specifically allocated to address those issues with people that are quote-unquote gene positive, pre-symptomatic, to address that and get disability benefits way earlier than otherwise would be justified just by occurrence of chorea. We have to really justify and document where the deficits are, and there are clearly deficits related to Huntington's disease. Not necessarily at the everyday functioning or maybe even family functioning, but of professional functioning, yes. You cannot be Navy SEAL anymore because certain things happen. And if you knew that and you were able to support it better, yes. But that is the experience, unique experience that you have to go through. And then you can teach other people about it. And then other people can project to their life and say, well, this might be a good moment to know. And I think that is why we think there is a shift now in understanding that It's not just a career when it occurs, and there's things you can do about it. You can objectivize certain things and better understand it, and not feel all these demons coming on you. And then the support system, you can address it before it gets dissipated.
Yeah. Well, the other thing that I think is really a really important thing that you just talked about was that in the beginning you needed medication to help you get on your feet, and now you don't need it so much because you have ways of prompting yourself to look at things differently. And I think so one of the myths is that there is nothing that people can do, but in reality what you have done is you've created some ways of thinking that help you slow down and use other parts of your brain to analyze your behavior than the automatic ones that are damaged in Huntington's. So that's like one thing. But I think the other thing is that you have surrounded yourself in a world that prompts you to succeed. So like Jimmy Pollard talks about creating prosthetic environments around people who have Huntington's disease. Like if you lose your leg, you get a prosthesis, right? So it's not like your whole brain is fallen apart. You have a certain very specific part of your brain that's giving you difficulty that you can create prompts around yourself, and you can create an environment around yourself that prompts you to succeed. And Huntington's is really a complicated disease. There's nothing about it that's not complex, but if people decide to call upon the other parts of their brain and to call upon the social structures around them and the people around them to help create these prosthetic supports, then they can get away without medicine because the world's not frustrating you nearly as bad as it used to.
I use nature to calm. When I get anxious, I use nature. That's what I do. I just get really calm. I do my breathing techniques. I know that sometimes people don't understand me. A lot of times I don't understand them. So to calm down, I just breathe diaphragmatically. I learn how to breathe diaphragmatically.
You breathe with your diaphragm.
My body, and then go in nature. And so when you do that, certain times of the day, I do it all the time now. I learn how to do that through time. And it's really calming.
Yeah. Yeah.
Use nature.
So you've partially answered this already.
Yes. Yeah.
When a person gets stuck on a thought, like that, because that immediate impulse is not really the issue, but they're thinking about the impulse and beating themselves up about it. I know it's not entirely their fault to get stuck, but is there a way to help them get over it?
So let me make sure I understand your question. If somebody with Huntington's disease gets stuck in a thought cycle and they can't get themselves out of it, right?
Yeah.
That's a very common problem with Huntington's. I think in terms of creating that prosthetic environment, what the problem is difficulty inhibiting that thought. Like you can't stop the thought. So somebody's going to have to externally help them stop that thought. So it's like the gentleman over here talking about utilizing nature and diaphragmatic breathing. Then or whatever it might be for the person with Huntington's, you distract them into that activity until you're able to break that cognitive cycle for them. I think the frustrating thing is that you can't reason someone out of that. You can't reason with a brain cycle. You have to actually physically do something to stop it. You have to actually do something as that person's caregiver, because it's not like they're able, the brain cycle is the brain cycle, and you can't reason. Most people try really hard to reason with somebody in that situation, and reasoning with someone doesn't work. Would you agree with that?
Yeah, I would agree with that, particularly with those perseverative behavior or obsessive behaviors. Sometimes just to get a point of reference point you out on the result and give you kind of like sequence where to go from to the next result. Because you don't want to just keep doing the same thing because the result's always the same. So you're going to say, okay, so you close the door, let's go to the car. Just have some kind of a plan of action, right? Because different type of the behaviors are governed by different parts of the brain. Unfortunately, the obsessive and the perversative behaviors that come from the area of the brain is frequently affected by Huntington's disease. But it can be dealt with the plan and a little bit of prompting, but with the outcome of the activity and the sequence to move on to the result.
I have one. So what's your best advice for people who are feeling isolated, alone, and kind of not feeling, I don't know, part of the community or part of their home environment or feeling alone with HD? I do a lot with that, on blogs and talks that I'm in. People feeling really alone and isolated in the community.
You want to take a stab at that? And I'll follow you. So the question was, how do people cope with feelings of isolation, like they're all alone with their disease?
Well, I think when you learn about having not necessarily Huntington's disease, but being gene positive, you are immediately struck with a grieving process. I think and there is everybody has very specific process they go through grievance, and there are 5 major steps of it. I think first is denial, second one is anger, then we have negotiation, and then depression, and then we have acceptance. So the feeling of loneliness, isolation comes from that process, and it's in a way actually even natural. But you don't want to get in a situation that you're stuck in that level, right? So generally, there is certain stigma to the psychiatric aspect or psychological aspect of Huntington's disease, and people don't tend to talk about it. But I think it is important to address it, because you cannot move on unless you really come to certain resolutions with it, right? So feelings of isolation, sometimes even guilt or shame, are frequent situations that people experience. But in a way, they are part of the natural process of grievance. But you don't want to enclose it to yourself. You want to find a point of reference. You want to talk to somebody. You can externalize it. You want to get involved with other people. See, what do you think? With the professional. You don't want just one person to talk about. You want to do many people to talk about. One thing you don't want to probably do is just to be on your computer and talk to the computer. Computer is going to give you distorted reality. So you really want to talk to people, the loved ones, the people that mean the most to you, and start building from there. And then move into the Huntington's disease community. There is a huge, tremendous amount of support within the community. You just have to tap into it and find your place in it. Find your role, find how that's going to play into your life. So, yes, there is a frequent feeling of loneliness and being isolation in Huntington's disease. And as I said, there is still some stigma about psychiatric aspects of Huntington's disease, and people don't like to talk about it. But it's very important to make the initial step, and the easiest way to do it is to come to the closest people first, and then address it. That's what it is. Here we are, and then move towards acceptance and how to deal with it.
We have time for one more question. There's one over here.
It was really a comment to kind of piggyback on this gentleman of sharing his incredible story. You had a kind of a question that was buried in your everything that you were saying, and that was, if I had an MRI, if I had a scanner, if I had something earlier, what would that help? And I guess for me, as a treating clinician, you don't even have to be in that place, because even if you're a family at risk and you talk about this, then it's knowing ahead of time that these are things that might come about and creating that whole support system. So you'll hear in the afternoon, I'm going to be talking to people at risk about talking to others. Chandler Swoop from HDO is going to be talking to kids about Huntington's disease and talking to the youth about Huntington's disease. That we really come from this place of, if we can communicate, if we can get people to communicate early, then it doesn't matter if you are gene positive or negative, because then you can say, if I'm at risk, can I have these support systems in place to recognize when I'm irritable, when there's something that's going on that might not feel quite like myself. It might have been war, it might have been something else, but it might have been exacerbated by the Huntington's disease. So having those things in place, even in terms of the social isolation, can be so helpful, because so many times we would get people come to the clinic, or people saying, if I could just get my loved one to the clinic, you're going to fix it. And that's another myth that I wanted to bring up, because we can't. We don't have these magic pills. So if I can't change that person's behavior, I might be able to change the family's reaction to the behavior. So it really is this whole family dynamic thing of talking to each other so early, because we can get these things in place well before they're needed, and at least be able to isolate them and understand them, and then help the family and the person with potentially with HD, if that makes sense, just to kind of pull that together.
Mm-hmm. I think we've got 5 more minutes if anybody else has some questions.
Well, I have one question, right? We have this, frequently we encounter, right? Like, what do doctors know about it? Doctors cannot do anything about Huntington's disease, so why would go and waste their time to see a doctor, right? So I think that is frequent, and that's probably one of those phases, like about anger or denial. You have to first you have to hear it from a doctor, probably, that you're gene positive, and then you say, well, maybe it was mixed up of a blood sample, maybe the test, or maybe recheck it, right? And then you have to hear, well, that's pretty accurate, and then you have to immediately into the next phase, the anger phase, and you are like an innocent bystander as a physician in that situation, when you have to, that it's coming, but there is something that you don't have a treatment for it, right? We do have treatments, but we don't have a cure. We don't have disease-modifying things, but there are lots of treatments, right? So, and there is lots of experience we can offer, right? So one of the preconceptions is that a doctor cannot do anything about it, right? And it's not necessarily a doctor, it's a profession. Doesn't even have it. Sometimes a social worker does much better job with certain things for you than a doctor can, right? So yes, there is lots of things we can do, but we have to get over that psychological process, or that process of learning and grievance, and process of understanding where we are, to get to that level of acceptance and working together as human beings, right? Not the computers. Computer is great. It has a tremendous amount of trivia and knowledge, but does not connect all these subtle dots that we have, and the situation with the family. So how many of you guys think this doctor cannot do anything for you? There we go.
Oh, I know there's more people out there that feel that way. I know there. So we'll close our eyes. We'll just all close our eyes. So I know there's more people in here that feel that way.
They can't make the problem go away.
No, can't make the problem go away.
Mary,
Mm-hmm.
I was thinking about kind of the situation Chad and I had gone through, or I had gone through with you, where my psychiatrist is kind of more old school, so to speak, in his determination with my anxiety and all that kind of stuff, because I'm gene positive. But what had happened is my mother had gotten into a car accident. There were so many things that happened. He and I got in an argument. I mean, I threatened to leave him that day and just go, I'm going to find a new psychiatrist. acknowledged him. I said, I'm the only one that has gene positive for Huntington's disease in your group of probably patients, because he had only studied it in college many years ago, and he has a well-developed practice, and, you know, he's well-known along the East Coast, but, you know, Mary had to intervene and talk to him about the new studies of being prodromal, and things that happen, because I have anger, I lash out, I love to throw plates, I mean, you know, there's all sorts of things that go along with that, and she was able to explain to him that there are other issues going on other than just the physical symptoms, because his thought was my diagnosis would come from my chorea, which I have none of. And my CAG level, or cage level, is larger than my mother's. But, so it really does depend. My mother had a different outcome, you know, and I have a different outcome now. So, but he does ask, and now I go in with Chad, so I'm not so angry with him. But I go in with Chad, and Chad can decipher what I'm trying to say, which is really kind of much easier on us now, because Chad can say, well, she naps every afternoon, versus I say, I sleep a lot, kind of thing. So logically, he and I are not on the same plane in that respect. So we did, you know, Mary did inform someone about the new prodromal things, because his idea was, we'll diagnose you when you have, you know, chorea, kind of thing. And that was kind of frustrating, honestly, as a patient. But thank you, Mary.
If Chad can look into the mind of a woman.
So I hate to wrap this up, but on that note, perhaps we should. So you're welcome, Chad. Dr. Edmondson, Dr. Cuturic, thank you so much for a very informative session. We're gonna take a real quick break.